All right, good afternoon, everybody. We're just giving folks a minute to log on and be ready for the workshop. So appreciate everybody's patience as we get that going. And as we do, just be sure to hit some housekeeping. You probably got the message as you logged on that we are recording this session. And so that'll be good for those of you who can't take notes fast enough from the information and maybe want to come back to it. So we'll have an opportunity to later post that as well so that you can follow up with it as needed. And we do hope to have time for some Q&A at the end of the presentation. Feel free, though, as you're going to put things in the chat, and we'll be able to kind of try to manage some of those questions when the appropriate time comes up. I want to introduce myself, Karen Pank, the Executive Director for the Chief Probation Officers of California. And so I'm guessing many of you have been on our informational workshops in the past. So I'll try to keep this part as short as possible, but we do appreciate you joining. We try to offer these workshops on Fridays because we know how much folks love to learn and absorb new information on a Friday afternoon, but really it's important for us to expose the probation field to a lot of the information that we have an opportunity to hear about and work on at the state level. So, and today is no exception. I want to thank Nolise Edwards, our special consultant to CPOC on a variety of topics, who has been kind of sitting in on all of the discussions in and around the CalAIM initiative, specifically as it relates to the justice involved portion. And so that's what today's kind of almost 101 is about. Some of you on this call may know a lot of the things that we'll be going over. Some of you, this may be the first time that you're kind of getting your feet wet on it. We are hoping to continue to send more information out and host more conversations to try, as this does roll out, try to make sure that probation is at the table and kind of aware of how your local conversations are going. So this is a great opportunity to learn a little bit about it from one of many people at the state level who are working on this. But we're very fortunate to have Brenda Grealish, who is the executive officer of CCJBH, and she promised me that she would explain exactly what all the acronyms are. So I'm going to let her do that. But we have been meeting with Brenda for many, many years. Many of you probably know her as well, but she's really served as a great, we were just joking before this, as a great translator, right? Sometimes there's things that happen from the state perspective. Sometimes it affects justice space, but it's coming out of the health space, and how do we kind of figure some of those pieces out? So while Brenda's not in only in charge of the good things that we're happy about and not at all responsible for any of the things that we have concerns about, we are really fortunate to have her with us today to walk through some of the things in the 101 space of CalAIM. And so with that, thank you again, Brenda. Appreciate you joining. And I'm just going to turn it over to you to handle the rest of the portion of this.
Wonderful. Thank you so much, Karen. Can you guys hear me okay?
Yes.
Excellent. Okay. Well, so great to see so many people here on a Friday afternoon, which makes me really excited that you're here in this space. It shows me that you're really caring and really wanting to learn more about CalAIM, which is California Advancing and Innovating Medi-Cal, and hopes to improve our delivery systems across our different sectors and really strengthening our partnerships to make sure that we're able to support some of the most vulnerable people in our communities and keep our communities safe. I guess what I'll do is I'll give you a little rundown of what I've got in terms of an itinerary for our time together this afternoon. I was going to give you guys a background of what CCJBH, which is the Council on Criminal Justice and Behavioral Health, is about. And so you kind of know why CCJBH is here today, why I'm here for CCJBH, a little bit about my background, so you kind of know what my experience has been working in these systems over the last 25 years. And then I was going to give you just a nice little 101, hopefully, on just the structure of our public healthcare system in California. That's something that really has helped me in the past, just understanding how these systems are set up or how they're designed, and how kind of the hierarchical flow is of the relationships within systems. And then give a little history, just a brief history on kind of how we got to be here today for CalAIM. And then I've got a video. We've been working very closely with the Department of Healthcare Services. We put together a little 101 video for justice system partners that we recorded with Sydney Armendariz, who's responsible for implementing the justice involved components of the CalAIM. And so I have a little video, about 20 minutes of Sydney just going through all those components for you. And that is something we actually have available on our website. So even as you're onboarding and looking to continue spreading the word, we've made that resource available on our website so you can tell your friends and then keep getting the word out, because that's really key at this point right now, is getting people socialized to and understanding what CalAIM is about, and particularly for the justice involved components. And then I will kind of wrap up, and then we will launch into questions. So just a little background about CCJBH. We've been around for about 20 years. We just had our 20th anniversary last year. We've been around, we were initially called the Council on Mentally Ill Offenders, and it is a council that is still chaired by the Secretary of the California Department of Corrections and Rehabilitation. At that time, it was co-chaired with the Department of Mental Health Director. But as many of you know, when we had public safety realignment around that same time, the former Department of Mental Health split and became the Department of State Hospitals, and the community programs transferred over into the Department of Healthcare Services. So now we have two co-chairs, and which is one, the director from DHCS and the director from the Department of State Hospitals. And a few years ago, we changed our name kind of in recognition of how the field was moving forward, and that it's not just mental health that's a concern, but also substance use disorders that are a concern for our population. We changed our name a few years ago to the Council on Criminal Justice and Behavioral Health. And just a little bit about what our council does. We are a 12-member council, and the representatives on our council are comprised of individuals that represent perspectives from both the criminal justice and behavioral health sectors. We have a pretty broad scope, so it's we don't administer programs, we aren't operations, but what we do is we try to lift up evidence-based and promising practices, things that are really working well to benefit our target population, which is individuals with behavioral health needs who have become involved in the justice system or who are at risk of becoming involved in the justice system. One thing I say to folks is, even though behavioral health and criminal justice helps define our target population, it doesn't define the needs of it doesn't represent or reflect the needs of our target population. So we really look multi-sector. So we look at those two sectors, but we're also looking at housing, employment, education, other social services, really to take a broad look and see what's going on in these different spaces, what's the latest and greatest, how do we bring folks together. So we do a lot of work trying to translate across systems, do dot connections, introduce people together who are working in similar spaces. We also do the full lifespan, so it's not just children and youth or adults or older adults, it's the full lifespan. And we also focus not just on state programs or state level programs or local level, but really the whole system. And so we look to parole, probation, and prisons and jails, really looking to go broadly and how we can do the most service in helping to share information and lift up the great work that's going on. We also will highlight what's maybe not working so that we can think about that and work a little bit more on trying to bring folks together, the right folks together to troubleshoot issues. So that's a background on CCJBH. I'm just very fortunate to be able to work in this space. A little bit about my background. Like I said, I've been in this field for about 25 years. I started at that former Department of Mental Health and Research, worked there for about 10 years, and then moved over to the California Department of Corrections and Rehabilitation into their Office of Research, worked there for about 5 years, learned so much, and really is the place where I got a stronger passion for this population. And so when that former Department of Mental Health split up and the community programs came into the Department of Healthcare Services, I had an opportunity to take a position back at DHCS. I say it was my old home, but it got supersized while I was away at CDCR, and really coming into that new space to be able to work back in specialty mental health services. And then while I was there, I broadened my scope to substance use disorder services as well. While I was at DHCS, I was kind of the justice involved kid there. So because I had come from CDCR, I had the fortune of being appointed to CCJBH as the DHCS representative. So I got to serve on CCJBH for several years before coming here to be the executive officer. So I will say too, while I was at DHCS, I started working on CalAIM. So you'll hear I'm a big cheerleader of CalAIM. I know it's big and it's probably very intimidating, but there's so much opportunity and promise, and just seeing everybody here today just warms me in knowing that this is such an important key group, probation, to really be a system and thought partner in bringing CalAIM to life. One of the great things about CalAIM is one of the key kind of tenets of it is breaking down silos. So even having you guys here today, it speaks volumes. So thank you, and appreciate CPOC bringing this together so we can shout it from the rooftops. And it's one of those things where you just kind of have to hear it multiple times, and then it'll keep sinking in over time. So just kind of the structure of our public health care system. So we have the federal Centers for Medicare and Medicaid Services, and that's kind of our federal entity, and we call them CMS, and CMS works with each state, and each state has a designated single state agency that works with the federal government to operate the Medicaid program, which in California is called Medi-Cal because it's a blend of the federal dollars as well as we have some state dollars in the program. So DHCS is responsible for administering the Medi-Cal program as a single state agency, and then DHCS will then in turn contract out with Medi-Cal managed care plans, primarily for primary care services, but there are some mental health services as well that are provided by the Medi-Cal managed care plans. And then we have what's called a carve out, where behavioral health services are carved out of the managed care plans into our county health plans, which usually are our county behavioral health plans is oftentimes what we'll call them, or we'll refer to them as, and that's usually mental health and substance use disorders, where those services are provided. And many counties have integrated, at least on paper, the mental health and the specialty mental health and drug Medi-Cal services. But part of CalAIM is going to be working more to integrate those services, which will be a really exciting thing, because it's almost like we've been operating two different delivery systems within one umbrella of behavioral health. So that's a little aside, but really exciting opportunities under CalAIM to really strengthen our behavioral health systems as well. So just a little bit, just so you guys kind of understand that flow of federal and then, state with DHCS, and then DHCS to the Medi-Cal managed care plans and the county behavioral health plans. And then oftentimes the Medi-Cal managed care plans and the county behavioral health will also subcontract or contract out for services to different community-based providers. So it's kind of a nice clean structure, which I appreciate now as I've even gone into other sectors and realized they don't necessarily always have that clean of a structure. So even as complicated as Medi-Cal is, it does have a very nice structure for the organization of the public health and behavioral health services. So just a little bit of a background on on the history of CalAIM and like, what is CalAIM? CalAIM, one of the things when the Department of Healthcare Services and their work with the federal government, we operate our healthcare and behavioral health delivery systems under what's called a state plan. It's kind of like the contract between the federal government and the state government. And then there's a series of waivers. And just to keep it simple, there's a variety of different kinds of waivers. But just for the sake of what we're talking about here in this space of CalAIM, we've got our 1915B waiver, which is really where we have kind of our core systems where those Medi-Cal managed care plans live, and the specialty mental health and drug Medi-Cal systems. And then we have what's called like an 1115 demonstration waiver, which I kind of think of as like the pilot waiver. And so we've got the core systems and the pilot waivers. And so our last waivers that we had was called Medi-Cal 2020. Our last kind of waiver where we had our Medi-Cal managed care plans was called Medi-Cal 2020, and that was in place from, I believe, 2015 to 2020. Although we extended it a little bit because of that public health emergency that happened right as that was ending. So we under that Medi-Cal 2020 waiver, the Department of Healthcare Services started implementing what's called whole person care pilots. And so many of you guys probably already may be familiar with whole person care pilots. Maybe you participated or your county participated in whole person care pilots. But really the idea of whole person care was to take just that, a whole person care approach to really addressing the healthcare, behavioral health care, and social determinant needs of some of our most vulnerable citizens. And so from those whole person care pilots, DHCS during that time went out, did listening sessions, learned a lot about how that was going, and a lot of that information informed a lot of what's gone into our our CalAIM waiver that we have now today. In particular, two new benefits came out of it. One is enhanced care management, which Sydney will go over with you in a moment for when I show you her video. And the other one is called community supports. And so community supports are those things that address social determinants or social drivers of health. And so those are two new benefits that are offered in our Medi-Cal managed care by our Medi-Cal managed care plans. Very exciting to be able to have those new benefits, again, that came from our whole person care pilots. And the other piece was the justice involved piece of it. So many of the whole person care pilots chose to focus on the justice involved population. And so much of the information, the experience that was gathered from those pilots rolled into inform the justice involved components of CalAIM. And so I think what was so exciting, even I was still at the Department of Healthcare Services at that time, and was so exciting about it was, you know, having the justice involved population specifically called out to really bring attention to the needs of that population, which again is why it's so critical for our probation partners, our sheriff partners, our partners at CDCR, even Board of State and Community Corrections, just at all different levels to be in and part of these conversations because you all are key players to bringing this to life. And so you probably had many pain points in your life as you've worked with this population. I think probation and parole have tried very hard over the years to kind of fill in the gaps where Medi-Cal couldn't provide services or didn't have services for this population. And so really these justice involved components of CalAIM are the state's way of saying, let's pay attention to this. Let's start meeting people where they're at and trying to get care as soon as possible to them to help support them to be the best them that they can be in our communities. So again, really excited to have all of to be able to propel the system forward in this way. Is it going to be easy? No. It's very complicated, but nothing to fear in terms of there's so much opportunity, kind of seeing the glass half full in the sense that, you know, there's opportunity to build relationships with system partners, opportunities to connect people to services in very streamlined ways that have been challenging in the past. And really that's kind of the promise of CalAIM, to be able to do that. So I think at this point, what I'll do is I will stop. This is just a little background to kind of get a foundation for you guys to be able to receive the information that Sydney's going to provide. One of the things that we at CCJBH try to do is, again, trying to educate, promote, really kind of get information networked out in our communities. And so we've worked very closely with Department of Healthcare Services and trying to support them in their efforts. And likewise, they've been very generous with their time and resources to support what our council's been trying to do to support our justice system partners as they come on board and start becoming familiar with CalAIM. So I believe I've got the sharing going. So I will have, I'll share my screen and have Sydney go over the components of CalAIM. Are you guys able to see my screen?
Yes.
Sorry, I can't see you guys.
Yeah, you're good.
Okay, all right, let's go. And I'm going to go ahead. It's like about a 20-minute video, but she does a great job laying out all the different justice involved components. And then once the video is over, I'll bring it down and I want to show you a couple different other pieces of information to flag for you, and then we will open it up for questions. So one moment, here we go. Oh, now the sound is not being shared. And it was just working right when we did the test beforehand.
It looks like it needs to be unmuted. I can see it.
Oh, here it is. Got it. Thank you. Thanks, guys.
Brenda, it looks like the sound isn't coming through.
Bill?
Yes.
A federal Medicaid law known as the inmate exclusion.
Now it is.
There it is.
Okay, sorry, you guys. Let's see here if we can go back. And sorry, you guys.
Assistance
Technology
or engagement that's necessary. So thank you so much for having me today. Next slide, please. So for the agenda, I'll start by providing an overview of the policy context and the rationale for the Justice Involved Initiative. Then I'll walk through the various components of the Justice Involved Initiative. And I will also talk about the opportunities for probation and parole officers as well, which is crucial to standing up this initiative and engaging our partners in this great work. So next slide, please. Up until now, due to a provision of federal Medicaid law known as the inmate exclusion, inpatient hospital care was the only service that could be covered by Medicaid for individuals considered an inmate of a public institution. In 2018, Congress passed the SUPPORT Act, which requires Health and Human Services to work with states to develop innovative strategies to help justice-involved individuals enroll in Medicaid. It also requires Health and Human Services to provide guidance on how to design projects to improve care transitions to the community for incarcerated individuals who are eligible for Medicaid. California, along with 14 other states, recognized the need for intervention and submitted Section 1115 demonstration requests to provide pre-release medical services. Through this 1115 Medi-Cal demonstration, California saw and received the first in the nation federal approval to provide a targeted set of Medi-Cal services to youth and adults in state prisons, county jails, and youth correctional facilities for up to 90 days prior to release. Next slide, please. So as I mentioned in the last slide, we have received the first in the country approval to authorize federal Medicaid matching funds for select Medicaid services for eligible justice-involved individuals in the 90-day period prior to release from incarceration in prisons, county jails, and youth correctional facilities. The intent of our demonstration is to build a bridge to community-based care for justice-involved Medi-Cal members, offering them services to stabilize their conditions and establish a reentry plan for their community-based care prior to release. Our demonstration is a part of our larger comprehensive initiative to improve physical and behavioral health care for the justice-involved population, and it builds on our substantial experience and investments on ensuring continuity of Medi-Cal coverage and access to care for justice-involved populations. With California's waiver approval, the state will test and evaluate the expectation that by providing targeted services in the pre-release period, we can improve health outcomes, advance health equity, and avert unnecessary use of care, such as emergency departments and inpatient hospitals. Next slide. So with the implementation of the Justice Involved Initiative, the Department of Healthcare Services hopes to advance health equity. We know that the issue of poor health outcomes, and death for incarcerated people is a health equity issue because Californians of color are often disproportionately incarcerated, including for mental health and substance use disorder related offenses. These individuals have considerable healthcare needs, but are often left without care and access to medications upon release. We also hope to improve health outcomes through this initiative. We hope to improve health outcomes by providing a targeted set of services in the pre-release period to establish a supportive community reentry process, which can then help individuals connect to physical and behavioral health services upon release. And then lastly, we hope to serve as a model for the rest of the nation. Since we are the first state to receive approval for this initiative, we hope that we can serve as a blueprint for the 14 other states or so that have pending justice-involved 1115 waivers. Next slide. So I'll give an overview about the components of the CalAIM Justice-Involved Initiative. Next slide. So the Justice Involved Reentry Initiative is part of a broader set of CalAIM initiatives focused on providing support for justice-involved populations. This includes the mandate that went into effect in January 2023 for all county jails to establish Medi-Cal application processes. And then the next puzzle piece on the slide is the pre-release services portion of the initiative. This is where in the 90-day period prior to release, we offer a targeted set of Medi-Cal pre-release services to justice-involved individuals. Then the next portion of the initiative will ensure individuals with behavioral health needs who are leaving incarceration are connected to services, and that the provision of enhanced care management and community supports upon reentry happens through Medi-Cal managed care. Next slide, please. So to give you more context about the pre-release Medi-Cal application, so beginning on January 1st, 2023, California mandated counties to implement pre-release Medi-Cal application processes in county jails and youth correctional facilities. Please note that the Department of Corrections and Rehabilitation has had pre-release Medi-Cal application processes in place since 2009. So completing Medi-Cal applications prior to release can help ensure that justice-involved individuals have Medi-Cal coverage upon reentry into the community. It will also ensure that individuals have access to pre-release services once they go live. Next slide, please. During the 90-day period prior to release from incarceration, eligible justice-involved individuals will receive a targeted set of Medi-Cal services, which include care management, physical and behavioral health clinical consultation services, laboratory and radiology services, medications that are consistent with the full scope of covered outpatient drugs under Medi-Cal state plans and medication administration, medications for addiction treatment, also known as MAT, and community health worker services. Eligible individuals will additionally receive covered outpatient medications and durable medical equipment like walkers and wheelchairs in hand upon release, consistent with approved state plan authorities and policy. Next slide. Medi-Cal eligible individuals who meet the pre-release access screening criteria may receive the targeted set of Medi-Cal pre-release services in the 90-day pre-release period that was described in the previous slide. In order to qualify for pre-release Medi-Cal services, and they must be in custody of a county jail or state prison, and they must also be part of a Medi-Cal eligibility group and meet at minimum one of the following healthcare needs criteria: a mental health diagnosis, a substance use disorder, a chronic or significant clinical condition, a traumatic brain injury, an intellectual or developmental disability, HIV or AIDS, or are pregnant or postpartum. And all Medi-Cal or CHIP eligible individuals incarcerated in a youth correctional facility are eligible. No clinical criteria is required. All individuals who are eligible to receive pre-release services will be eligible to receive enhanced care management post-release. This will help ensure continuity of care between the pre- and post-release periods. Next slide, please. For those eligible for pre-release services, a care manager will be assigned to establish a relationship with the individual, understand their health needs, coordinate needed services, and plan for community transition. This includes connecting the individual to a community-based care manager, like an ECM provider, who they can work with upon their release. Healthcare providers will ensure individuals who require behavioral and other healthcare services, medications, and other medical supplies, such as a wheelchair, have what they need upon reentry so they can continue to receive the care they need after their release. Members can also qualify for post-release enrollment and enhanced care management, also known as ECM, and community supports, including housing and food supports, to help them build stability as they re-enter the community. ECM care managers can meet Medi-Cal members via telehealth prior to their release to establish a relationship and to support their re-entry into the community. In addition, to achieve continuity of treatment to individuals who receive behavioral health services while incarcerated, DHCS will require correctional facilities to facilitate referrals and linkages to post-release behavioral health providers and share information with the individual's health plan. Prior to release, the pre-release care manager will be required to share the transitional care plan with the post-release care manager and schedule and conduct a pre-release care management meeting. Next slide, please. Enhanced care management, also known as ECM, is a Medi-Cal managed care benefit that supports comprehensive care management for members with complex needs. Each managed care plan member enrolled in ECM will have a dedicated care manager who provides interdisciplinary, high-touch, person-centered services to the member, including coordinating all care across physical, behavioral, and dental health. ECM care managers primarily provide services through in-person interactions with the members they serve, where they live, and seek care or prefer access to services. ECM for justice-involved individuals is already live in 17 counties that had whole person care programs that serve the justice-involved population. ECM for justice-involved individuals will go live throughout the entire state on January 1st, 2024. While ECM for justice-involved individuals is not yet live in many counties, justice-involved individuals may already qualify for ECM through another population of focus that is live statewide, such as adults and families experiencing homelessness, pregnant or postpartum adults, or adults with serious mental health or substance use disorder needs. Next slide, please. ECM eligibility criteria for the individuals transitioning from incarceration population of focus aligns with eligibility for pre-release services. As such, all individuals who received pre-release services while incarcerated will meet the criteria to receive ECM post-release as a part of their Medi-Cal managed care services. And as a reminder, eligible adults include those that are Medi-Cal enrolled are transitioning from a correctional facility or have transitioned within the past 12 months and meet at least one clinical criteria listed on the slide. All Medi-Cal enrolled children and youth transitioning from a youth correctional facility or who have transitioned within the past 12 months are eligible and no clinical criteria is required. So for example, please note that eligibility under the adult or youth criteria depends on the facility in which the individual is in custody as opposed to the individual's age. For example, a 22-year-old in custody of a youth correctional facility would be eligible for ECM services under the youth criteria. Next slide, please. Individuals transitioning from incarceration have a wide variety of social and clinical needs at reentry. Some of these clinically linked needs may be supported through non-clinical services offered through the Community Supports Program. The community support offerings differ by managed care plan and county and include services such as housing, navigation, and deposits, respite services and recuperative care, medically tailored meals, sobering centers, asthma remediation, day habilitation, and more. Not all services are offered by all plans, or are they offered in all counties. A list of community supports by managed care plan and county are available at a link in the next slide. In this slide. We envision that care managers will connect the individual to community support services, and probation and parole officers can also refer the individual to services as well. Next slide, please. So here's where you all come in. Here are the opportunities for probation and parole officers to engage in this work. Next slide. Probation and parole officers and their clinical staff have a key role to play in supporting individuals reentering the community and accessing newly available CalAIM services. This includes officers and clinical staff checking DHCS's eligibility verification system to ensure that individuals are enrolled in Medi-Cal. If an individual is not enrolled, the officer or clinician can connect them to their county social service department to complete an application. Officers and clinical staff can ensure the individual is enrolled in a managed care plan if eligible, and support enrollment in a managed care plan if they are not enrolled. Individuals must be enrolled in a managed care plan to access enhanced care management and community supports. If an individual is enrolled in a managed care plan but not receiving enhanced care management, officers and clinical staff can contact the managed care plan in which the individual is enrolled to inquire about ECM enrollment and to make a referral. If officers and clinical staff believe that an individual may benefit from a community support service offered by their managed care plan in the county they reside, they could additionally contact the managed care plan or the individual's ECM provider to note that the individual may benefit from that service. Officers and clinical staff can also coordinate with an individual's ECM provider to ensure that the provider has knowledge of the individual's probation and parole requirements. Lastly, officers and clinical staff should notify clients that California is currently redetermining Medi-Cal eligibility due to the end of the public health emergency from COVID-19. Clients should update their address if needed and check their mail for their renewal packet. If they do not complete the renewal packet, which will be sent to the address on file for them, they risk losing their Medi-Cal coverage. And please note that redeterminations will happen on an annual basis going forward. Redeterminations were paused since the start of the public health emergency in 2020. And officers and clinical staff should support individuals as they go through the redetermination process on an annual basis going forward. Next slide. So please, I encourage you to please visit the Justice Involved Initiative website for more information, and please feel free to reach out to the Justice Involved email that's listed on the screen with any questions or concerns. Officers and clinicians can use the fact sheet focused on enhanced care management that has been developed by CCJBH for reference. So again, if you have any questions or would like any more information about this initiative, please email us at the address listed on the slide. This concludes my presentation on the CalAIM Justice Involved Reentry Initiative. Thank you so much for your time, and I will go ahead and turn it back over to Brenda Graylish to close us out. Thank you.
Awesome. Excuse me. And then I think what I'll do now is pull up on Sydney's presentation, and we provided this to the CPOC team, and actually we're working on posting this to our website as well at CCJBH. But in addition to Sydney's presentation that she gave, that she just finished, there are little appendices that are included in that PowerPoint document, which has a nice little cheat sheet for the go live dates for the ECM populations of focus. So as Sydney had mentioned in her presentation, last year we had several populations of focus going live for our justice involved. The ones that we've really been tracking are individuals with serious mental illnesses, individuals with and individuals who are homeless. And a lot of the whole person care pilots had already been working to serve the justice involved. There were a couple more populations of focus that were added on January 1st, 2023, individuals that were at risk of long-term care institutionalization and those transitioning from nursing facilities. And then just in a couple of weeks, there will be the adults without dependent children or youth living with them who are experiencing homelessness. And then some of the children and youth populations of focus that will be eligible for enhanced care management. And then another key date for you all to track is January 1st, 2024, which is when the individuals transitioning from incarceration population of focus goes live. Although I will say that because last year the serious mental illness, substance use disorder populations of focus went live, probably about 80% of our folks are going to fall into the existing populations of focus that have been implemented last year. So you don't have to wait, as what I'm saying is that these referrals can be occurring today to the managed care plan so that these individuals can get assessed. And then come January 1, just being a justice involved population of focus, we'll get folks closer into the door for enhanced care management. And so let's see here. I'm going to go ahead and stop my share for a moment. So Sydney covered quite a bit of information. I hope that kind of, for those of you who have been exposed to a lot of this already, I hope this kind of just helps to kind of reinforce what you've already been learning about CalAIM. And then for those who are new, I will say it's probably feels like a lot, but it's just like anything new. It feels like a lot at first, but then you'll just kind of hear it over and over again, and it'll start sinking in every time you start thinking about it. So some of the things that CCJBH has been working on to help support DHCS in CalAIM implementation. About a couple years ago in 2021, the whole DHCS executive team came to our council and did a presentation on CalAIM as it related to the justice involved. So we have that webinar that we've got on our website. We've been participating in a lot of the justice involved advisory groups for DHCS. I know CPOC has been there as well. So, kind of weighing in and making sure that perspective is represented. Again, what we do is a lot of dot connecting. So we try to make sure that if there's folks, if we know the DHCS is working on something for the justice involved space and we know subject matter experts, we try to connect DHCS with those subject matter experts. Or if there's something that DHCS is in need of, we would try to help them try to get connected up to the right folks as well. We have a legislative report that we're mandated to do every year. So, we'd be remiss if we didn't put in our 2 cents on what we think would be helpful for the justice involved population. And that ledge report is for the administration and legislature to, and really, kind of for all of our community members and our different departments who are looking to implement, given all of our conversations, what we've learned, we will articulate that into recommendations that we feel will help optimize implementation. And then accompanying this 101 that you just saw Sydney do, we developed a fact sheet or a cheat sheet of the CalAIM justice involved initiatives that CPOC has access to. It's also on our website. So as you're leaving this particular webinar, you can have that little cheat sheet or that fact sheet, which will go through all of the different components that Sydney just went over. So ECM, enhanced care management, community supports, the 90-day in-reach, the Medi-Cal pre-release application, and you'll be able to just see at a quick glance what it is, who it's for, what the dates of implementation are, and just a brief description of it. So, so really just, trying to do what we can do to help. And then the onboarding video. And I will just say, just as kind of a note, is that, this is a multi-system, multi-level, multidisciplinary collaboration, between and within all these groups. And, we've got primary care, behavioral health, we've got criminal justice partners, housing partners, social services partners, federal, state, local, community, individuals, the people who we're serving. We've got all the provider networks. We've got providers from the primary care networks. We've got the providers from behavioral health care, law enforcement partners and their providers, the continuums of care for housing in our state, and the communities, the consumers and their family members. So lots of different stakeholders and players. But again, that's really kind of a key pillar of CalAIM, is to really try to bring all these entities together towards this common goal of implementing this new infrastructure that will really allow for improvements to be made to improve health, improve community safety, and just really address a lot of the issues that we see in our society for these very vulnerable individuals. And I will say, kind of new to this space as a note, that Medi-Cal managed care plans are kind of the new players. So I think county behavioral health, county probation, very used to working with one another, and have been, at that level, communicating for years. But Medi-Cal managed care plans, even though ACA, Affordable Care Act, went into place in 2020, what was it, 2016, no, 2014, Jan 1, 2014. And they've been able to serve this population. We just haven't seen a whole lot of services being provided. Even as we at CCJBH, we have our Medi-Cal utilization project, where we look at people coming out of CDCR and look at their Medi-Cal enrollment and service utilization. And even though they can access a lot of these behavioral health services in particular, we don't see that utilization as high as we would like to see it. So, so the Medi-Cal managed care plans really are new to this space. I will say I'm going to be speaking to them next week, and they are very curious. When I've gone into the healthcare space to talk about CalAIM from a justice perspective, one thing I always ask is, does anybody know about evidence-based corrections? And like, nobody knows. I mean, I think there was a conference I was at a couple of months ago, and I think we probably had a couple hundred people that were in the audience, and I think I saw one to two hands go up. So I think that cross education is going to be going in all directions to really implement this to its fullest potential. And I just want to say that the relationships and the collaboration is just going to be key to making this work. It's like developing a shared vision and goals amongst partners, really taking time to expand that knowledge and understanding. I will say, even as I've been trying to do work across different sectors, I was bringing the CDCR folks and housing folks together, and they were using the word services, and it meant totally different things than services. So, but yet here we had a few meetings, everyone's talking services, and it took a moment to go, wait a minute, what are you talking about with services? And same thing happens with the word treatment. It means different things. In a justice space, we'll talk about treatment in terms of criminogenic interventions to address criminogenic needs. But in treatment, you have clinical, like behavioral health treatment for serious mental illness and substance use disorders. So it's taking that time to share that knowledge and having that mutual respect and support with one another. And I know these sounds kind of like maybe soft skill types of things, but it is just absolutely going to be so important because these relationships are going to be key. And then just really, I want to acknowledge the complexity of the work again, and that there will be frustrating times. But, I think really looking at the process of being frustrating, not one another, and like just really focusing on banding together to troubleshoot challenges and seeing them as growth opportunities. Because I think what DHCS has done in terms of building out this infrastructure for CalAIM, it's a beautiful infrastructure. There's so many things that address long-standing issues in these systems that have happened for decades. And so, you know, here's this infrastructure to be able to kind of loosen it up and get the flows going, and being able to improve the types of services that are received, the access to them, and the quality of those services. And then really taking that continuous quality improvement approach, recognizing that it's not going to be perfect out of the gate as much as we all want to think it could be, but you know, some things will be perfect, but there are going to be some things that just, you know, require several iterations to get right, and that's okay. You know, it's just going to be part of the process. So again, I really thank all of you for giving me a chance to come here today and just share this really exciting initiative. And just again, I can't stress how key it is to have your partnership and your expertise at the table. You know, I think CPOC's done a great job of, you know, really putting that perspective of what is necessary to serve this population, but having the probation, different probation departments being a part of this as well. And in terms of, you know, what to do, you know, what can be done today, I know the 90-day in-reach piece is, as Sydney had mentioned, starting no sooner than April 2024. And from a probation perspective, the juvenile facilities are going to be needing to work on that piece of it. But what's live today is that enhanced care management benefit, and you know, really being able to have that supersized care manager. I call it the care manager of the care managers, maybe the air traffic control. And I will tell you, like, for me personally, I'm a mom of a child with special needs. I have to coordinate my son's care across several different delivery systems. I am his lead care manager. I'm his enhanced care manager. So really, that's what this is to try to have somebody who's doing kind of that air traffic control amongst all the different systems. I think I saw something come through in targeted case management. There was a question in one of that I saw pop on the bottom, and I think folks can still get TCM, but it's just got to be separate from what's happening by the lead care manager in the enhanced care management provider. And I know DHCS has guidance about that, but really that's something that can be done today. Those referrals can be made to the Medi-Cal managed care plans to get those assessments going. And as Sydney had mentioned in her video, we've been working with DHCS on developing a informational flyer with probation and parole in mind, to help you guys know, like, what ECM is, who's the populations of focus, and what are the steps to doing that that enhanced care management referral to the Medi-Cal managed care plan. And we actually developed it last summer. And then when parole was kind enough to test it out for us, and we realized that the first step, which was figuring out if somebody was enrolled in Medi-Cal and had selected a Medi-Cal managed care plan, was call social services to get that information, and parole called that the line, and it was a very long wait, and it was just not going to be a feasible thing. So working with DHCS, they got in there, rolled sleeves up, and that's how you heard Sydney talk about access to AVES, which is the automated eligibility verification system for Department of Healthcare Services. Parole and probation now has access to be able to submit an enrollment application to DHCS and get a username and password to be able to look that information up and know what plan they're in. Karen, were you gonna say that?
Yeah, I was just gonna stop you for a quick second, because we're getting a few questions in the chat, and you're providing a lot of information, and probably people can't write that fast, and I want to be sure that we give them a chance to kind of catch up, because it's a lot. As you said, there's a lot of information, a lot of work has been done, and it's so helpful to have you kind of go over some of those things. So just does that work now for us to maybe just kind of take a couple of questions, because it might give you a flavor of the types of things that probation folks
Absolutely.
need to kind of think about. So and Elise, you had your hand up, so you may want to start.
No, yeah, I was gonna say the same thing, that we had two questions in the chat, Brenda, one which you alluded to. The first one was, how is it envisioned that ECM interact / overlap with TCM? That was the first one. And the other was any shared cost to juveniles families to participate. Those were two questions.
Yeah, and so like I mentioned with the TCM, DHCS has guidance out on that, but somebody could get TCM and enhanced care management. There just have to be, it's got to be very separate from one another. But but there is a way to do that. And we can get that information to you. And then in terms of, I think, Michelle, for your question on share cost to juveniles family to participate, I guess I'm just thinking in the Medi-Cal program, and these are children and youth who are going to be enrolled or who are enrolled in Medi-Cal. And so there shouldn't be a share cost for these children and youth and their families.
Looking around, Karen and Brenda, I don't see any other questions in the chat, but are there others who may have a question? And raise your hand. We can get it in for you.
I think I'm thinking, can I ask one thing about just logistically? I think we had mentioned, but I just want to be sure because folks were probably jumping on and off. Are you going to be able, or will we be able to give them access to the video that you just ran and or the slides? Because I know, as you mentioned, there's some appendices that'll probably be of very particular relevance to this particular group.
Yep. And thanks for the question. So yes, the video is already posted on our website. And as I was prepping for this today, I realized that we didn't get the slides up yet. So, or not the slides, but the PowerPoint presentation, but it's nice to have that as a reference as well. So I'll work with my team to finish getting the rest of the materials posted. And if you go to our website, usually I just Google CDCR CCJBH, and then our website will pop up. And under the projects section, you'll see CalAIM as a banner, and you can just click on CalAIM and you'll find this 101 video that I just showed with Sydney. And so please tell your friends, or if you guys are onboarding your team members, please feel free to use that video. The cheat sheet that I had mentioned, that is also up there, the fact sheet that has just a quick quick excerpt of the justice involved proposals, or the proposals that relate most to the justice involved population. And then that enhanced care management informational flyer. We are currently working right now with parole. Like I said, we're just testing it out. We tested it out last summer, and we had to make some tweaks. We've just made those tweaks. And so we're actually testing between parole, their behavioral health clinicians, their behavioral health reintegration clinicians, and LA Care, which is the largest Medi-Cal managed care plan in LA County. At CCGBH, we've been facilitating those connections, and they've been developing relationships and partnerships to be able to start working on those enhanced care management referrals. So they had to watch the 101 video last week, and so LA Care is actually going to train those the behavioral health reintegration clinicians in parole on how to do those enhanced care management referrals. And so we're hoping to see how that goes within the next few weeks, and we will then post that informational flyer. We want to test it out one way first before giving it over to parole to make sure that it's good to go for you guys. And then we'd love to partner with you guys to maybe do a little testing on it on the probation end of things, and then we'll post it.
I appreciate that. And you just touched on something I was going to follow up with and make sure that our folks on the call who are mainly probation kind of understand that we know that the testing between maybe what parole processes are and other state entities as they're rolling it out might look very different than local, i.e. probation. And,
yep.
and so we probably will need to do both. And I appreciate that you referenced that. I had a question going back to the care managers. You know, this is kind of a new position, so to speak, correct? Is that, yeah. And,
yeah.
And who hires them? Who do they report to? How does that work?
Yep. So it's a new benefit in the Medi-Cal managed care plans. The Medi-Cal managed care plans are the ones who are required to implement the benefit. Many of them are contracting out for these to enhance care management providers in the communities. Some, like say Riverside, they were a whole person care pilot. They have their Riverside University healthcare system that is their ECM provider. So they might contract with the health services system in the county. Some could contract out with behavioral health. So I know in Los Angeles County, like LA Care does have a contract with county behavioral health to provide enhanced care management. Other plans in the county might do the same, and across the state, some managed care plans have those kinds of relationships with their county behavioral health and choose to have their county behavioral health be their lead care, their enhanced care management provider, but some might not. Some might actually just contract with community-based organizations to be their providers as well. And so basically it's a new provider type, enhanced care management provider, and the person who would be leading it is within that enhanced care management provider is the lead care manager. And so the lead care manager will be responsible for coordinating care across all the Medi-Cal delivery systems. So that would be primary care, that would be specialty mental health services and drug Medi-Cal services and dental, like whatever that person needs that's a Medi-Cal service, that lead care manager within that enhanced care management provider would be responsible for scheduling all those appointments and making sure people have transportation to get to those appointments. And then also they can provide community support. So in the video, Sydney referenced that there's the community supports benefit. That's optional. So whereas enhanced care management is a required benefit in the Medi-Cal managed care plans, community supports is an optional benefit. But I will say many of the Medi-Cal managed care plans have opted into providing a lot of those community supports. So housing deposits, housing navigation, tenancy sustaining services. A lot of the managed care plans are doing that because they know providing those services avoids the higher cost services that'll hit them later.
And so to that end, a lot of those community supports services and even maybe some of the ECM supports are types of things that might be linked to or overlap with some of the court orders. So those on probation will have, as you well know, be under court orders for, the case planning and the various different things that we would be doing. Is there been discussion about how those overlap and how to address that at all?
I think that's why the probation expertise is needed in that space. And so that's why it's so critical to have probation's voice at the table to really think this through and think about how that's going to work out. And because like I said, this is a lot of cross education that's going to be happening. So this might not even, what you just mentioned, Karen, might not even be on the radars of the Medi-Cal managed care plans. And maybe some might be more savvy than others. But I think that really encouraging our probation folks who are here today to start reaching out to the Medi-Cal managed care plans in your county, making those connections, I think are going to be key. And it's just really good having somebody to call, for them to be able to call and lean on their probation partners in the county. I think I know they would very much appreciate that.
Well, I think those are all conversations, obviously, that need to take place, probably are taking place in different counties. As I noted, it seems like there's some in counties in the chat that maybe have kind of gotten a head start on some of this. So appreciate that. And I know that the conversations are ongoing with DHCS in some of the rollout. And so for our probation folks, just to know that there is a lot more to come. I think, I'm going to speak on behalf of probation. I know there's a lot on all of your plates right now. And so this can seem like a lot and seem overwhelming, but I think we'll do our best to continue to work with the state to be sure that we're getting all of the information out to folks because these conversations are not going to, and relationships and processes won't happen overnight. And so we'll need to put forth lessons learned. And those are the types of things that hopefully we'll be able to do in future workshops as well.
And I will say DHCS has made funding available to support our justice system partners in doing the build outs for all of this. So it's the PATH funding. And so I know they're on round 3 for this funding. And really you guys you can start applying for that funding now. And you can use that funding to do things like kind of the infrastructure thinking, kind of the thinking, the planning, to be able to do that and bringing your system partner, even taking that money, getting consultants or whoever to come or hiring additional staff to be able to do this kind of work. So there is funding to support probation in doing all of this. And especially that's going to be important for that 90-day in-reach part of it, because excuse me, that there's a lot of different nuances there that go into that process. And that part of the waiver, the CalAIM waiver, just got approved in late January. So I know DHCS is working on doing a lot to kind of operationalize it, get guidance out to counties in a timely manner. But that is going to be something key to stay tuned in. And if you haven't been on the DHCS Justice Involved Initiative website, I highly recommend doing so, checking it regularly. I know CPOC does a great job. Like Nolise and I have talked, she's already on a lot of stuff. she's tracking so much, but even for all of you, just I think the wider the net is cast, the better, to make sure everybody's not missing anything, because there is a lot coming out at one time.
I think that's a great suggestion, and I think it is a lot coming out, and more so every day. And at one point in time, I think for those who might have been looking to see and try to learn more information, there wasn't a lot built out on the website around the justice involved piece of CalAIM. So now that we're getting to that part, it's nice to know that there will be more information, and it's kind of good to thank you. Brenda, I was hoping that you would pop it into the the chat. So that's perfect. And yes, thanks Nolise for putting your email in the chat as well, because I think there will be follow-up questions from this. I think we are, even though we've been sitting in a lot of these meetings, and I think there's been a lot of discussions, and as we've said, some counties might be already implementing some of these pieces. I think there's still a lot of work ahead of us, and so we should be having more to come. In light of all of that, are there any other questions from the group? If not, I think we've kind of asked you quite a few. Thank you for Brenda for coming on to the informational workshop and providing all of this information. It's a great 101 place to start. If as I like to joke, if you're not sure yet how to spell CalAIM, let's start here, and then we can kind of move from there. And I don't think if you're sitting in the audience thinking, oh no, that's actually me, I think there's a lot of us there, so don't feel like you're alone. So more to come, and again, really appreciate you taking your time, especially on a Friday afternoon, to spend with us, Brenda.
Yeah, and everybody else here too. Thanks you guys for the invite. I could talk about this all day if you couldn't tell.
There's a lot to talk about, and so it's great to know that you're a resource for us. So so with that, Nolise, anything else that we need to cover? All right, well then, thanks everybody. Enjoy the rest of your Friday and your weekend.
Thank you very much.